So today we'll be discussing about the sonographic techniques of the lower limb vascular examination, including arteries and veins. So for this purpose, I have a lecture with the different tests. So here we go to today's lecture. For the vascular examination of lower limb, it's important to know about the vascular anatomy. Just for example, if we compare the vascular examination with the drawing, so that will be too easy to give an example of the expertise of a driver and reaching to the destination of the actual driver. Just for imagine a person who is a well expert driver and have a very good vehicle, but unfortunately he didn't know the road map of Lahore. So is it possible for that driver to reach his destination? I think it's impossible. So to reach a destination, you should know the anatomy, that is the road map, and the techniques, that's the expertise in your driving. And state of the art modality, which is your best vehicle. So now, for that purpose, you should know about the vascular anatomy. And for vascular anatomy, you can take help from Google, from YouTube, and from many more sites. You can even learn on cadaveric anatomy from different universities. So there you will from there you will have video lectures with demonstration. And nowadays it is not difficult to learn anatomy from the online resources. So here you can see an image of the vascular anatomy. So that's too easy. As you know, by the bifurcation of abdominal aorta and IVC, it divides into right and left iliac arteries and iliac veins. So here we'll talk only about the arteries, and then the same way the deep veins having the same names, and almost they are accompanied with their arterial counterparts. But the superficial venous system will be a bit different, so we'll discuss that individually. The right and left iliac arteries and veins are soon divided into internal and external iliac arteries and veins. The external iliac artery continue to pass through the inguinal ligament and to either right or left leg, while the internal iliac artery supplies the local area, for example, pelvis and the adjacent regions, and the veins are draining that part. So while passing to the thigh region leg, by passing the inguinal ligament, the external iliac artery becomes common femoral artery. And soon the common femoral artery is divided into its deep branch, which is profunda, and superficial branch, which is the continuation of that femoral artery. So the femoral artery will be bifurcated. Here you can see in this image into profunda femoral artery, this one, and femoral artery, which is this one, which is labeled over here. This is femoral artery. Okay. Then the profunda femoral artery supplies the local thigh region, while the femoral artery is coursing at the middle aspect of the thigh deep to the muscle and the adductor canal, then move slightly posteriorly and form the popliteal artery, which is represented with these dotted lines, and give up multiple branches to the knee region. Just for example, superior medial genicular artery and inferior medial genicular artery and patellar anastomosis. And on the lateral side, similarly, superior lateral genicular artery and inferior lateral genicular arteries, and their genicular anastomosis. And then by passing through the popliteal region to the distal leg, and soon it bifurcates into anterior tibial artery, which is labeled over here, this one, and posteriorly to tibio-peroneal trunk, which is labeled over here, tibio-peroneal trunk. Okay. Then the tibio-peroneal trunk is bifurcated into peroneal artery and posterior tibial artery. After entering the ankle region, the anterior tibial artery is continued as dorsal aspidus artery. Posterior tibial artery is reaching to the posterior aspect of the medial malleolus, and peroneal artery to the posterior aspect of the lateral malleolus. And then enter the plantar region and forming the superficial and deep plantar arch. For ultrasound purpose in novice persons, you should know the anatomy of these main arteries. Some anatomic variation will also be encountered. That's why you should know the anatomic variation as well. It's the same way, the deep venous system having the same names, but there is a bit variation. And there is more variation in the venous system as compared to the arterial system. So as you know, the venous system is bringing blood back towards the heart from periphery. That's why you have to describe its anatomy from distal to proximal. So as you know, from distal region with the posterior tibial vein, just posterior to the medial malleolus, you can localize the artery as well as veins, but posterior tibial veins are most commonly in pair, and they are varying in number from 2 to 7. The same way, anterior tibial veins are also varying from 2 to 7, and peroneal vein as well. But most commonly, they are 2 in number. So one artery will be accompanied with 2 veins. One posterior artery with 2 posterior tibial vein, and one peroneal artery with at least 2 peroneal vein, and one anterior tibial artery with 2 peroneal anterior tibial vein. All the veins are equipped with valves, and these are bicuspid one-way valve. They are permitting blood to flow proximal from distal to proximal, and they are permitting they are preventing blood to move backward. That's why the direction of the flaps of these veins are from distal to proximal. And the number of these valves vary in different veins, but they are more in the small peripheral veins as compared to the large central veins. Sometimes in some individual external iliac vein have a valve, but most of the individual, the external iliac vein have no valve. And then the femoral vein have almost up to 5 valves. Then the posterior anterior tibial vein and peroneal vein have the number of these valves varying from 7 to 11. Similarly, superficial venous system. In the superficial venous system, great saphenous vein and small saphenous vein are included. This superficial venous system is also equipped with these valves. The great saphenous vein is originating from the anterior aspect of the medial malleolus, and small saphenous vein is originating from the anterior aspect of the lateral malleolus. Just for example, here you can see the small saphenous vein is originated from over here, while the great saphenous vein is originated from here. The small saphenous vein is coursing posterior to the distal leg, and the saphenous fascia above the gastrocnemius muscles, and the great saphenous vein is coursing in the saphenous fascia at the medial aspect of the leg. Similarly, in the similar saphenous fascia. So that was all about the main anatomy of the vascular system of the venous and arterial of the lower leg. Now we are coming towards the sonographic techniques. So first of all, it's mandatory to expose the entire leg of the patient, because In cases of any hesitation, the clothing of the patient can hinder in the examination. That's why the privacy of the patient is mandatory, but the exposure of the region of interest is utmost important for accurate examination techniques. For the lower limb, arterial and venous examination, the patient should lie supine on the examination table, and the transducer should be placed at the inguinal region and transverse at this region, just below the inguinal canal at inguinal crease. This is the region where you should place the transducer and shot. Sorry, this is the level of the bifurcation of the iliac artery into internal external, and then after passing the inguinal ligament at this region, you have to take the excess at the inguinal crease just below the inguinal ligament and short axis view, and you will have the artery, vein, and the great saphenous vein in this patient. Just for example, we are talking about the anatomy of the right side, left side, this leg, this one, okay? So here the vein is large in size and that is central, accompanied by a lateral artery, small in size and non-compressible. And this femoral vein is joined by great saphenous vein, and this appearance is a bit looking like a Mickey Mouse. That's why this is called a Mickey Mouse sign. So here you should know about the different parts of this Mickey Mouse. The central is femoral vein. The lateral is femoral artery, and the femoral vein is joined by great saphenous vein from the lateral side. So while localizing this great saphenous vein, first of all, you should know about the competency of the great saphenous vein at this region, which is called saphenofemoral junction. Because this saphenofemoral junction is almost guarded by a valve, bicuspid valve, and the flaps of the valves are directed towards the common femoral vein. It permits only blood in this direction and prevents its backward flow. But in cases of any incompetency, the blood can flow in the reverse order. And that will be a sign of venous insufficiency. So first of all, you should know, you should interrogate this saphenofemoral junction for any signs of incompetency. You should check the compressibility at this level. While compressing at this region, then you will get an image like this. This will be the same femoral artery, but now the common femoral vein and the great saphenous vein will collapse and they will disappear. So in cases of normal femoral vein and great saphenous vein, they will disappear with compression. You will get only the femoral artery. Right? Then rotate your transducer uh, at this level on the common femoral artery. Try to make an angle of insunation at almost 60 degree, less than 90 degree. Uh, you can make this angle manually. While having angle of insunation less than 90 degree, then you have uh, to perform electronic steering of the beam as well. So with that electronic steering, you will get an angle of insulation less than 90, less than 60 degree. And at that angle, Doppler angle less than 60 degree, you will be able to uh, to predict the occurred velocity in that. Then move your transducer down. Preferably, the grades of Venezuelan should be followed in a left patient because here you can see this is the grades of Venezuelan, this one, and here you can see you have visualized the femoral vein, the grades of Venezuelan, and now you are coming to follow the grades of Venezuelan in short axis view while using plenty of gel at the middle aspect of the thigh. At the knee level, the great Venezuelan is moving a bit posterior, and then you can follow at the middle aspect of the leg. Here you can see it will have some superficial branches as well. And at different location, it have communication with the deep venous system. So that communication between the deep and superficial venous system is called perforating venous system. So now you should know about the venous system. The venous system is composed of three systems. The superficial venous system, the deep venous system, and the perforating venous systems. This system is called perforating venous system because it perforates the muscle fascia and reaches the deep venous system and transfer blood from time to time and region to region from superficial venous system to deep venous system. So it should be kept in your mind that the normal blood flow direction and the perforating venous system is from superficial to deep. Okay, so that will be the direction. That will be the direction of blood flow from superficial to deep. While interrogating the entire superficial venous system in short axis view, while following it to the medial malleolus, uh, you will have different perforators. Normally, the localization of perforator is a bit difficult, but in cases of any abnormality, the perforator will be dilated and that will be too easy to be localized. And by applying color Doppler, in the cases of incompetent perforator, the blood flow direction will be reverse R. You can check its bidirectional flow. In normal circumstances, there will be superficial to deep blood flow, but the transducer compression and sudden release, the blood will flow in the reverse order from deep to superficial. So in that case, it's mean the perforator is incompetent and dilated, and the blood is flowing in the on both the direction, from superficial to deep as well as from deep to superficial. So that, in that case, the perforator will be incompetent, but there will be no concomitant any deep veins thrombosis. That's why the blood will not continuously flow from deep to superficial. But in cases of any thrombus in the deep venous system, just for example, you can say that the posterior tibial vein, this is thrombosed. So what will happen? The blood at the distal to thrombus will move from deep to superficial venous system at these perforator, okay? And here, if you evaluate these perforator will be dilated and the blood will flow from deep to superficial venous system, and then from that superficial venous system, the direction of the blood will be distal to proximal, which is the routine direction. And after bypassing that clot in the deep venous system, it will again move from superficial to deep venous system. So at that region where there is clot, that segment is bypassed with the help of superficial venous system. So in that case, there will be continuous or persistent deep to superficial blood flow in the perforator distal to the thrombus and the deep venous system. And again, you can check the competency of these veins at different level by Valsalva maneuver. So you should know about Valsalva maneuvers. During Valsalva maneuver, the patient is asked to take deep breath, and then the patient should try to expire try to expire with closed glottis. With closed glottis, mean that is only try, not to expire the breath, to develop pressure on the abdomen. So by developing pressure on the abdominal IVC will collapse. And in cases of any incompetency, the blood will flow in backward direction from superficial, from proximal to distal. So normally the blood is flowing in the venous system from distal to proximal because all these veins are guarded by multiple bicuspid valves and which prevent backward flow of blood. But in cases of incompetency, by incompetency we mean the valves are now no more competent, that are unable to prevent backward flow of blood. So in that condition, chronic venous insufficiency, the blood will pool peripherally. And during that peripheral blood pooling, varicose veins will develop and so on, edema. These are the common signs of chronic venous insufficiency. There will be edema, there will be varicose veins, and the leg will be comparatively warm because the blood is flowing and they are coming too close to the skin. So by touching the leg, it will be warm as compared to the other leg or normal legs. Then you can rotate your transducer because if you are going to follow the great stiffness vein and small stiffness vein from proximal to distal or distal to proximal, so that will be easy to follow it in the short axis. You by placing the transducer in short axis, and you can compress it at different location or different level for any thrombus or any thrombophlebitis or to elevate the vessel wall. For taking off blood flow from the arterial system, just for example, you have taken the velocities, flow pattern of the femoral artery at the inguinal region by rotating the transducer and achieving an angle of insulation less Doppler angle less than 60 degree. You take the velocimetry. Then at the adductor canal, once again rotate the transducer, and by achieving a site axis which is in true proximity to the vascular structure in the adductor canal, and again try to achieve a Doppler angle less than 60 degree, and once again you can take the blood flow velocities in the adductor canal. The wall of the arteries should be interrogated for any calcification or deposits, because you will have multiple deposits, and in the cases of arteriosclerotic disease. So in cases of early arteriosclerotic disease, the blood flow velocities will be the same, mean there will be no hemodynamic change, but only calcium will deposit in the vessel wall. But in cases of confirmed arteriosclerotic disease, hardening of the arteries wall, there will be hemodynamic change as well. There will be now change in the flow pattern or spectra of the normal artery and arteriosclerotic diseased artery. You can check the compressibility of the femoral vein at the adductor canal by compression. Similar compression, but now there will be needed much more compression as compared to the proximal area. Then turn the leg of the patient more externally to make easy access for the posterior tibial artery and vein. So that could easily be localized just posterior to the medial malleolus. So just posterior to the medial malleolus, placing the transducer and short axis view, you will have 3-dot or 3-0 appearance. The central one almost be the artery, and the side ones will be the vein. But in some cases, you will have 3 veins with a single artery. So for differentiating arteries and veins from each other, you'll have to apply compressibility test. So by applying compressibility, veins will be compressed while the artery will remain at its normal position, and then followed proximally. So once you localize the vessel, then it's easy to be followed proximally or distally. And then for the peroneal vein, you can turn the leg of the patient internally and slightly rotate the patient on the contralateral side. So you can localize the peroneal artery and vein just posterior to the medial malleolus. Again, you can check or localize it by applying power Doppler and compression. Once you localize the peroneal artery, then you can follow it. But Anatomically, there is a great deal of variation in the peroneal arteries compared to the posterior tibial artery. That's why the localization of the peroneal artery is a bit difficult as compared to the posterior tibial artery and veins. For the anterior tibial artery, you will have first of all to localize the dorsalis pedis artery while flexing the knee joint at 30-degree angle and placing the foot flat on the examination table. So you can localize the dorsalis pedis artery while placing the transducer at this region and then proximally follow it. So this dorsalis pedis artery is actually the continuation of the anterior tibial artery. So the anterior tibial artery can be localized at the anterior aspect just between the tibia and fibula. And by palpating it, placing transducer and sharp exercise,